Blame the cat.
Well, no. Some of these will be edited, so don't worry. All right. Well, welcome. Second review. So last time we did anti-epileptics, right? And we said we're gonna pick up from last time we stopped. So just remind me, what did we cover last time?
Kind of talked about narrow spectrum versus broad.
We got to Lamictal.
And we kind of broke down epilepsy to like focal, partial, and then non-focal.
Which medications we stopped at last?
Yeah, Keppra was the last one.
So, and I talked about gabapentin, pregabalin, just a couple of new medications I'm gonna mention. And as I said, some of these medications are new. However, practice has been increasingly using them right now. So one of these medications is tiagabine, and the drugs that works on the GABA analogs, or so the GABA mediated system. And you know, GABA being an inhibitory neurotransmitter. So this medication is gonna be pretty much either increase the concentration of GABA at the synaptic cleft, inhibit the metabolism of GABA by the GABAergic enzymes on the synaptic cleft, or just pretty much like gabapentin and pregabalin, which is GABA analogs. However, they have nothing to do with GABA, they just utilize the same receptors. So to start with, gabapentin and pregabalin. So these two agents are interesting. They look like GABA, they both are amino acids. They're charged molecules, negatively charged, meaning that they will be needing active transport. As you know, all amino acids are actively transported, since most of them are charged. So the idea of these drugs is just to look like GABA, use the same transporters from the gut and from the blood-brain barrier in order to reach their site of action in the brain. However, their mechanism of action has nothing to do with GABA. They don't affect its receptor, they don't affect the GABA pathway. Their mechanism is kind of unknown, and it's known as alpha-4 delta-2 calcium channel inhibitors. And how's this going to be related to anything? Nothing, just like any vague mechanism of action that really doesn't tell you what it is. These are narrow spectrum, meaning they are used only for focal or as an adjunct to generalized seizure, meaning especially the tonic-clonic variants. These drugs will not be used for absent seizure, just like the other narrow spectrum agents from the first generation. So, and pretty much they are not used by themselves, really, guys. I mean, how often you see gabapentin patients on gabapentin just for seizure? They are often used as an adjunct to be added if you have a neuropathy from diabetes, or you have like a sleep disorder, or but nothing on just the pure anti-epileptic per se. And you know, gabapentin, very safe, started low, goes, started like 100 to pretty much 400 to 300 daily dose divided TID, and it can go all the way to 3 grams. And literally, these low doses has no anti-epileptic effects, and doses above 1.8 grams up to 3.9 grams a day, this is where gabapentin start to have this anti-epileptic. However, in practice, we don't use that. Same thing for pregabalin. However, pregabalin is more dosed carefully. As you know, the range between 75 to 300. Higher doses, of course, yes, doses above 150, but pregabalin is a scheduled drugs and it has some kind of euphoria and some, especially if taken concomitantly with other CNS acting drugs or alcohol. So pregabalin would be also the same thing. Now, being charged molecule looking like amino acid, this is going to be an advantage for us to be 100% renally eliminated, 0% bound to proteins. All right, so this is the nice thing about them. These are 100% renally eliminated, as is no any important interactions. As for side effects are very easy. Being again molecules, negatively charged amino acids means they make osmotic gradient, and this osmotic gradient will literally draw fluid from the intravascular to the interstitial place. Draw fluid, yes, when they deposit in tissue, and that will lead to generally weight gain and edema. Other than that, just CNS depression and sedation. These are the side effects. All right, now 2 other GABA drugs is one called tiagabine. and you can say they have all the GABA somewhere in their name. So tiagabine is different. Tiagabine is a drug that literally inhibits the reuptake of GABA from the synaptic cleft. So when you get on a level of synapse, when you get a release of GABA, all right, some of these GABA, if they are not be taken, they need to be reuptaken to the pretty much to the presynaptic in order to be released. Tiagabine somehow there is an autoreceptor here that pretty much inhibit the reuptake, and tiagabine pretty much what it does, it just increase the rate of recycling your GABA so that you will have another rub by inhibiting the negative feedback pathway from the autoreceptor. Tiagabine is rarely used. It's also renally eliminated. Their use is focal adjunct. The drug is 100% renally eliminated, meaning it needs to be adjusted. Renal failure doesn't have any interactions. Tiagabine side effects is pretty much mild in nature, and the drug has been associated with some mood disorders and changes in mood disorders. Nothing specific about it. Not that potent, the drug. The last one is kind of important, especially for peds, which is called vigabatrin. And have you heard about this medication before? Say well. So this is kind of one of the drug of choice for a condition called West syndrome or infantile spasm. It's a type of seizure that happens in neonates and children, and this seizure is associated with literally infantile spasm, especially they get like myoclonic. So it's not a generalized clonic, it's a myoclonic, which is just repetitive, brief jerking. And for West syndrome, it's pretty much for children, it's associated with failure to thrive and failure to grow, and may develop to other types of seizure. Vigabatrin is kind of a very narrow spectrum, and it is used only also for focal. However, it is something for peds and this West syndrome or infantile spasm. All right. The issue is that two things I want you to remember about vigabatrin. First of all, how does it work? It inhibits the deamination or basically of the GABA. So when you have GABA released, there is a glutaminase, an enzyme that pretty much digests the GABA or the glutamate in the GABA. And basically vigabatrin inhibit the glutaminase activity, much like acetylcholinesterase inhibitors, which inhibit the cholinesterase in this synaptic space. What about vigabatrin? Vigabatrin is NIOSH, I think 3. It's associated with teratogenicity and I'm not sure if it's associated with carcinogenicity, but it is very highly, especially if you want to. So protective equipment required. It's on the NIOSH list. It is a hazardous medication. This is one. Second of it, vigabatrin can cause vision loss, and this is something very challenging when you are doing this for a neonate, especially for someone you really have to evaluate. So it's very difficult to evaluate vision in children, and there should be a specific kind of counseling tips on how to tell if there are any associated problems with just vision in such an age group, and counseling about vision loss with vigabatrin is a big deal. These are the GABA analogs. We have done Topamax and zonisamide, we have done Keppra, we have done levetiracetam. There are a couple of more I want to talk about. A drug called felbamate. Have you heard about this? While all anti-epileptics are CNS depressant, felbamate, counterintuitively, is actually a CNS stimulant. And the drug can cause insomnia and increase alertness with respect to other all CNS depressants. So this is something special about it. Another special thing about felbamate is never to be used as a first line. It's often always as a last line because of its terrible safety profile. It requires a guardian and a patient enrollment in special program for felbamate prescribing, much like RAMS, but I'm not sure this is also RAMS. A guardian or the patient must sign a consent with the treating physician who has a privilege to prescribe felbamate, to understand the side effects and to be consistent with the monitoring, because the drug is extremely liver toxic and can cause bone marrow suppression. So, which of these first generation had some kind of a similar profile? You remember? It was carbamazepine that had aplastic-anemia and bone marrow suppression. So due to that reason, felbamate needs to be in a special program, and it's often used as a last line agent when you don't have any other agent. Other one I'm gonna mention is ethosuximide, which is another narrow spectrum. And we mentioned briefly ethosuximide last time, and we said it is, you know what seizure type is for ethosuximide? Absent seizure, yes. This is among one of three, and what other two are for absent seizure? Yes. So, ethosuximide zonegran is kind of your first line agent for absent seizure. Why? It's safe and effective. Valproic acid is very effective, however, valproic acid could be associated with literally so much side effects, most importantly in kids who will most likely have absent seizure, delayed mental growth. So cognitive dysfunction is very common in valproic acid, and this should be an issue. That's why valproate is not a first line for absence. Lamotrigine is pretty effective for absent seizure, but for the same reason, for the rash and all these life-threatening hypersensitivities, is not often considered as first line. Ethosuximide, as on the other hand, is kind of a very relatively safe and very effective drug, and it is almost always the first line agent to be thought about in absent seizure. Side effects, and again, when you reach side effects vague, like GI side effects, increased risk of infection, may be associated with some decrease in white count that is not clinically significant, you know very well the drug is very safe, relatively safe. All right. So I guess that concludes anti-epileptics in general. There are some other drugs, something called refunamide that is not widely used. Refunamide is a scheduled drug, but I don't remember what's the schedule of it. Refunamide is also used for focal seizures, and the side effect is the only drug that you will see there is a PR interval shortening. And have I done EKGs and antiarrhythmics? Oh. Okay, just it's associated with EKG changes, but the EKG changes is PR shortening, and relatively this is kind of not something common because drugs that affect the PR usually widen the PR, like beta blockers or CCBs. So this is for you to keep in mind. Another drug, a very important drug, is have I done which one? Lorazepam. We haven't done this one, but I'm not gonna. I think that's enough for the most common anti-epileptic. The rest of them is drug like phenobarbital or all. Then have I told about pregnancy? So technically, management of anti-epileptics in pregnancy involve continuing whatever agent the patient was on, as the risk of seizure during pregnancy is more catastrophic than just what this not arbitrary, but this somehow teratogenic side effects, with the exception of one drug that you would never start a pregnant female on unless she was on it before, which is valproic acid. Valproic acid, due to its neural tube defects, can be catastrophic, and that be associated with literally NTD, a neural tube defect, and therefore that's why never start valproic acid initially in a pregnant female unless it was previously started, and that needs to be discussed with the patient. You know, the patient, is this the first time? Can we just jeopardize discontinuing valproic acid and start something else? So valproic acid is known for its neural tube defect. Phenytoin exposure in pregnancy has been associated with kind of delay, what they call, it's like a fetal baby alcohol syndrome, which is pretty much associated with mental retardation and kind of delayed growth. Carbamazepine is associated with cleft palate, which is the rabbit is the failure to flues of the cleft palate. And finally, phenobarbital is associated with congenital cardiac abnormalities in kids. So PDA, bicuspid, bileaflet aortic valve, any kind of these tetralogy of Fallot, any kind of these congenital abnormalities in kids. Any female on any pregnant female on antiepileptic needs to be at least on 1 to 5 milligrams of folic acid daily. That's it. All right. Do you have any questions? Shall we start psych? Do you want psych? I can start reviewing psychiatry, and I'll be focusing on reviewing classes more than medical conditions. But
Really quick, you said that any female that's on an anti-epileptic should be getting the folic acid.
yes,
Okay.
of childbearing age should be on folic acid
Okay.
of 1 milligrams. All right, antidepressants. All right. So, just a basic idea. This is what we're gonna go to from neurology to psychiatry. Antidepressants are the drug of choice used for monopolar depression, which is literally just major depressive disorder, MDD. It's also used as often for mainly as the drug of choice for general anxiety disorder, PTSD, panic attacks, and all the anxiety disorders. Never use an antidepressant for a manic patient or a bipolar patient. Even if the bipolar is in the depression phase, never give antidepressants because antidepressants can exacerbate manic attack, and you will convert a patient from a depressive state to a manic phase. So while it would make sense to use an antidepressant in the depressive phase of a bipolar patient. This is actually very wrong, very dangerous, and in that situation, you would use just an antipsychotic with the lithium or the valproic acid. All right, antidepressants, yes.
Why do you see that all the time then? Like manic patients or bipolar patients, every time I see one, they're always on like sertraline.
Yeah, the idea is that with practice is always confusing. And some of these patients may not even have a complete diagnosis of bipolar, or may had like a depressive episode that resulted in attempt to suicide. And that would be because when you have a suicidal patient, that's a very different. And technically there shouldn't be on sertraline. What's the dose?
I don't remember, it was like
50 if I add it to 100.
I mean, it's on the low dose, but still, again, if you check the literature, it is very strongly not recommended to add an antidepressant. And common exams, pretty much puts you in a situation where you give you a depressive patient, give you some sign of mania, you would know this is a type 2 or a type 1 bipolar with depressive episode. And antidepressants, especially SSRIs, not even if something like a TCA may cause some sedation, that's fine, but SSRIs, specifically fluoxetine or paroxetine, are pretty much very discouraged to be used during the depressive attack. And in this situation, an antipsychotics and aripiprazole, Abilify, is being approved for this indication right now to be used in bipolar depression. So I'm not really sure that with psych, it's always not have, just like you see never combine two antidepressants and you see it being used at the time. For psych, it's all over the place, and whatever puts the patient back on remission. Some of these warnings that we have is somehow pretty much very exaggerated. Like any combination of two antidepressants is something you learned about it to be completely contraindicated. Yet in practice, this happens all the time, and the risk is there. However, serotonin syndrome is a rare but yet fatal. And in our DI consults, we always, put the disclaimer that combination is not recommended. While the risk of SS or serotonin syndrome is very rare, yet it could be fatal, and it's up to the discretion of the treating physician. So we're going to explore so many classes here. We have SSRIs, SNRIs, TCAs, and NDRI or NRI.
I would say AOI.
Oh,
Yeah, I've never heard of that one.
this is bupropion.
Oh, okay.
MAO inhibitor. And you got something like serotonin reuptake inhibitors, serotonin antagonist reuptake inhibitors, and you got some alpha 2 agonist. You know which one is this? Huh? It's mirtazapine. All right. Let's start with the top. So SSRIs. However, they usually textbook always start with TCAs because it's the oldest and the first class to ever develop, and it kind of builds. And I like to start with TCAs because when you know that these drugs, these classes came in, well, not mayo inhibitor or something else. These classes came into practice just to overcome the side effects and the intolerability of TCA. So if you can identify these side effects of TCA, you'll be very able to make sense why we have SSRI and SNRI, and you'll be able to kind of just on top of your mind kind of assess or describe some of these side effects without even if you don't have any information about the drug. So let me start with TCAs, then go to the traditional SSRI, SNRI flow. So TCAs, tricyclic antidepressant, is the first class of antidepressant ever came to market. It involved drugs of 2 generations within the TCAs. Just to give you an idea, TCAs are structurally similar to carbamazepine, and this may be associated with some cross-reactivities. I don't know about the rash. This is a very good question, but I don't know if carbamazepine rash puts you away from TCA. We can search that. So, tricyclic antidepressants is the concept of antidepressant is that I want to increase the amount of monoamines, especially the monoamines that makes me happy. And this situation is going to be serotonin and norepinephrine, to a lesser extent dopamine. All right. So we don't want to increase dopamine much. As you know, dopamine has a lot of movement disorder, and dopamine can be associated with dependence. So dopamine is something else. So the first class ever to come is TCAs, and TCAs literally, if you remember the shape of the 2 synapses, whenever a serotonin or a norepinephrine gets released, it needs to be recycled again by a certain reuptake enzymes. These enzymes, pretty much TCAs is going to be inhibit the reuptake inhibitors enzyme, much like thiamine, to be honest with you. And that would increase the amount of serotonin and norepinephrine available for postsynaptic interaction and continuous of the action potential. All right, these drugs share the same active site like cocaine, and cocaine actually works like a TCA. It's literally a TCA. It's not a TCA by structure. It's a local anesthetic, but it has the same binding site, which is the reuptake transporters of serotonin and norepinephrine. All right. TCAs is very special, being non-selective. And whenever you mention an antidepressant that is non-selective, means that you're also going to have inhibition on 3 other sets of receptors. One of them is going to be H1, histamine. One of them is going to be M1, and etc., muscarine, and one of them is going to be alpha-1. So the side effects of TCAs will gonna be a direct extension of their pharmacology due to their non-selectivity. So whenever I give you this or I tell you a TCA, you automatically know half of the side effects just by knowing what's these receptors pretty much, this neurotransmitter is responsible for. SNRI and SARIs are drugs that specifically designed in order to lose effect on these, and therefore that's why they considered safer, and they don't cause the side effects of TCAs. Now TCAs have other side effects, but these are the most common. So what happens if you block H1? What's the outcome?
Drowsy.
Sedation. What you happen when you block muscarinic receptors? Which are?
Dry mouth.
It's called
Blurry vision.
sluts.
So dry mouth.
Opposite.
From your
Mad as a
insides.
What's in the eyes?
Blurry vision or dead.
Dry eyes and blurry vision due to cycloplagia. Dry eye.
Friends of you. Friends of you. That's harder.
All right. Dry mouth, dry. What about in the gut?
Constipation.
What about in the urine?
Retention.
My favorite, heart. Yes. All right, and not to mention the CNS side effect that comes with anticholinergic side effects. So pretty much, and living with anticholinergic is no picnic. These side effects are pretty much impairs the quality of life and associated with a great morbidity. More importantly, what happens if you block alpha 1? Huh?
Increase blood pressure.
Increase?
Decrease.
Hypotension? How it's gonna be clinically shown as?
And then you
Get orthostasis.
oh,
Which is when you are in a reclining position, you may not see hypertension. Is the idea when the patient shift from a reclining sitting into a standing position, the arterial supply, due to the effect of gravity, becomes more, so the arterial supply or the carotid supply to the brain diminishes, and you will witness a drop in systolic pressure when you stand. So orthostasis. All of these, sedation with orthostasis, you can have falls, you can have fractures, sedation, you can have impairment of, conducting daily activities, and not to mention these terrible side effects. For that reason, these are never used as first line. On top of that, and these are the daily side effects that you're gonna have, which you may develop tolerance after 2-3 weeks. So the idea is that you're not gonna be living with this, you may have tolerance, but TCAs are very discouraged, being one thing is that they are toxic if overdose. You work in the poison center, have you encountered TCA poisoning? And it's just similar to any Benadryl poisoning, so.
Usually, yeah, I think people get anticholinergic the most.
Yes.
TCA.
So toxic if overdose, toxicity from TCAs gives you two things. It gives you CNS side effects and give you cardiac, and the cardiac is the one that is deadly. So toxic if overdose on the CNS level, they cause seizures, and they are never to be used in patients with literally epilepsy. All right. Second and most important, cardiac. You have any idea what could aggressive anticholinergic can do on the cardiac? QT, prolong, and this life-threatening form of ventricular arrhythmia, which is, yes, Torsades de Pointes. All right. So Torsades is very common toxic overdose, and it's very common they give you a vignette, patient presented with, loss of consciousness. Patients were found to have patients who had irregular rhythm, they were seizing, they were unresponsive, they had dry eyes, dilated the pupils because of the cycloplegia. So, and they have a pack of drugs, administered, and prescription for a TCA, and TCAs and management requires, so pretty much gastric lavage or irrigation if within 1 hour, and activated charcoal if within 1 hour. The issue is that these are anticholinergics. Anticholinergic delay gastric emptying. So even if you attempted to remove the drug after 1 hour, you may keep them under observation and keep administering the charcoal, because as the drug effect wears off, GI function resumes, and whatever drug that has not been dumped into the intestine will be dumped again, and you will witness another episode. And that's the same thing happens with opioids. When you have opioids overdose, you give the naloxone, they respond, and after 2 hours later, they go into, again, a tachypnea, or they lost consciousness. And that's effect because there is some still drug in the gut that has not been absorbed due to the delay gastric emptying that these drugs. And once you establish that back, you're gonna reabsorb it again, and you go. So what you do is basically gastric decontamination within 1 hour with activated charcoal, and the drug is dialyzable, TCAs, thank goodness. Sodium bicarb needs to be given to enhance elimination, and magnesium is given for the torsade whenever you have it. So these are standard management for TCA. Dialysis and bicarb for enhanced elimination, magnesium for the heart, for the arrhythmia, for torsade. Okay, 2 grams push. Seizure, if they have seizure, they get phenytoin, but you don't do a pre-seizure prevention, yes?
Does the magnesium, like release the pyloric sphincter, is that what it's doing?
Is it for your QT?
No, it's for the QT prolongation. Magnesium is to go and to increase the repolarization of the
Did you say
heart.
bicarb?
Huh?
Did you say bicarb?
Yeah, bicarb.
That's what I meant, that one.
Backward helps you eliminate it by increasing. I think increases the acid increases.
Yeah.
It makes your blood more basic, so it makes it easier for you to filter out the.
It just enhance urine elimination of the drug.
Okay,
Yeah, none of the GI. You're giving IV.
okay.
All right. Now, within the TCAs, there are two subsets. So now we're gonna know their drugs. And to take it more advanced, we're gonna have two forms of TCAs. We have something called the tertiary amine and the secondary amine. Are you aware of this? The tertiary amine and secondary amines. So tertiary amines include the older agents, which is, I'm not gonna go all over them, just the ones that you are using them in practice. So this is your amitriptyline. And the other one is imipramine. These are known as tertiary amines. Secondary amines are the active metabolites of these two. So what's the active metabolite of amitriptyline? Nortriptyline, yes. And imipramine, desipramine. So what's the deal with that? Is that tertiary amines are more selective on serotonin reuptake more than so 5-HT reuptake more than norepinephrine reuptake. As for secondary amine, they are more for norepinephrine reuptake rather than 5-HT, which is serotonin. Now what does that mean really, clinically? The secondary amine will have less, by far, these side effects compared to the tertiary amine. The tertiary amine being older parent drug, more selective on, meaning that they are not that selective on norepinephrine, and being not that very selective means they will have the alpha blockade activity, the histamine blockade activity, and the muscarine blockade activity. So, comparing within the same class, a secondary amine is by far more safer than a tertiary amine and TCA in terms of these side effects. That doesn't mean that the drug won't cause all the things that if they can overdose, especially that in high doses you lose selectivity and you start blocking everything. Yes.
So why does more serotonin activity, more serotonin activity make it so you have more of those?
Just in terms of selectivity, but it just happened to be that the more selective you are on serotonin, more than epinephrine makes you makes you more prone to have the anticholinergics, directly due to selectivity on these muscarinic, histaminergic, and alpha receptors. So this has nothing an explanation, just an explanation of pharmacology, but it doesn't make you able to relate why do you have more side effects with tertiary amine compared to secondary.
Okay.
All right, onset of action of TCA, usually they take about 4 weeks, 2 to 4 weeks. Onset can be witnessed within the first week. However, full effects needs to be assessed following at least 4 weeks of starting antidepressants, drugs like TCA agents. Serum levels are often sometimes obtained for these drugs, by the way, especially in terms of when you suspect toxicity. So there are serum levels, but you don't memorize them. All right, let's talk about SSRIs now. Now that you know the side effects, Now that you know the side effects of these drugs, SSRIs, on the other hand, will have much less side effects in terms of being very selective, and that's why they call them selective serotonin reuptake inhibitor. It's just to emphasize that you no longer have this. So your side effects or your pharmacology is going to be focused on serotonin only. So drugs of this class exhibit kind of the safest and the most effective. However, they also have their own issues. So SSRIs, I'll just start with pretty much more selective on serotonin, And as you inhibit, however, they don't have any postsynaptic serotonergic activity. And the more advanced as you go through these classes, you're going to see some of these drugs inhibit the reuptake at the same time activate some kind of a post receptors, and I will give you an idea about that shortly. The idea is when you want to block serotonin, how many serotonin subtypes there are of receptors? So many discovered, the ones that mammalian, about 7, and each of these 7 have subfamilies. So it's the most diverse receptor in the body, which is serotonin. The idea is that I want you to know 1, 2, 3 serotonin receptors. One of them is 5-HT1A, 5-HT2A, and 5-HT2C. Now, these will be, especially 1A and 2A, these are going to be, I just mentioned these. There are some important ones like 1D and 1B, but for the sake of depression and anxiety, this needs to know activation of 5-HT1A leads to anxiolytic effect, an antidepressant effect. So makes it more better. Activation of 5-HT2A is the exact opposite of 1A, and 5-HT2A leads to increased anxiety and depression. 5-HT2C activation leads to increased weight gain by increase of appetite. So my ideal antidepressant would be a drug that activate 5-HT1A and inhibit 5-HT2A. However, this has not been yet discovered in SSRIs, and SSRIs by far just inhibit all the reuptake of serotonin, yielding some available, and the one that catches 1A is going to be related to a response. That's why the response somehow is going to be a bit very delayed here. So SSRIs have literally a delayed response compared to all other antidepressants. Now we know for sure is that when you have an SSRI, you don't evaluate response. You start low, you start tapering up, and you won't evaluate response until 4 to 6, 6 to 8, sometimes 12. It really depends on the SSRIs. As fluoxetine versus citalopram, they're completely different. Fluoxetine half-life can go up to 90 hours or 10 days. Citalopram is within less than 10 hours. So pretty much it's this statement about 6, 8, it's according to the antidepressant or according to the SSRI, fluoxetine being the most delayed onset compared to citalopram. However, general rule of thumb, 6 to 8 weeks to start evaluate. Usually patients start to get a response after 4 weeks. This is the onset, but in order to know that the drug is in steady state, 6 to 8 weeks is appropriate. But in the meantime, previously, you are increasing the dose till according to patient's tolerance. So these drugs doesn't have any anticholinergic side effects, so they're they don't have antimuscarinic side effects, they don't have alpha blockade activity, and they don't have antihistamine effects. So pretty much they don't cause sedation, they don't have anticholinergics, and they don't cause orthostasis. What do they cause then? These drugs are relatively safe, and their side effects is pretty much increased GI side effects. All right, they are activating antidepressants, meaning that these antidepressants makes you active, not sedated like TCA. So they are dosed in the morning after meal. All antidepressants, all SSRIs needs to be given after meal, except sertraline, it doesn't matter. You can give it before or after. All right. So they can cause GI side effects, and that's why you give them after meals. They can cause activation, so you dose them in the morning. However, this is not almost always. Sometimes an SSRI can cause sedation, especially with paroxetine. So literally, when you go to look at the side effects, you'll see sedation versus insomnia. So which one? It depends on patient response. Some patient get sedation, some patient get insomnic. So literally, you're gonna be playing around with the dosing schedule based on patient response. General rule of thumb, all of them are dosed in the morning. Paroxetine may be the one is dosed at night, as paroxetine is more likely to cause sedation compared to insomnia. Other very important side effects of SSRI is their sexual dysfunction, and that could be that. And you know, when you go and read up package insert, it's much less reported than what is actually in practice. Sexual dysfunction from TSC, from SSRIs, is very common, very troublesome, and you know, it leads to this vicious circle because sexual dysfunction depresses mood, you know, let's just go over that circle again. So sexual dysfunction really needs to be addressed, patients really needs to be counseled, and yeah, sometimes a switch, and you can switch within the same class, or if it didn't work out, switch to a different class, or I'm gonna tell you what do you do with sexual dysfunction. So the sexual dysfunction, what kind of sexual dysfunction you get from SSRIs? More likely you may get something called retrograde ejaculation, which is pretty much instead of ejaculation outward, the ejaculation goes into retrograde and stays in. So this is pretty much, and this could lead to an obstruction. Other forms of sexual dysfunction is literally erectile dysfunction, delayed ejaculation, priapism has been reported, and actually some of these SSRIs has approval to be treated for premature ejaculation if taken within 1 hour before sexual intercourse. I think paroxetine, fluoxetine has labeled indication. There is one SSRI, it's called peripherally acting SSRI, that is approved only for sexual premature ejaculation in Europe, called dapaxetine. I don't know if it's available here. So dapaxetine is an SSRI that is doesn't go to the brain, so it doesn't have any CNS, and is usually given before intercourse for delayed premature ejaculation. So increased ejaculation latency, retrograde ejaculation, erectile dysfunctions are all common side effects in sexual dysfunction from SSRIs. Management, decrease the dose, switch, or add bupropion at very low doses. Bupropion addition at low doses can negate the sexual dysfunction, especially these two are extremely high risk of sexual dysfunction between SSRIs and SNRIs. All right, let's take our drugs here now. Yeah, fluoxetine. Paroxetine, fluvoxamine, sertraline, and I'm using this order for one reason only. Citalo and escitalopram. So this is basically an order by the longest half-life to the shortest half-life, and by order of highest drug interaction to lowest or even negligible drug interaction. So fluoxetine has an active metabolite, you know very well, and any active metabolite, if you don't know the name of the active metabolite, just put a NOR. So norfluoxetine is the active metabolite of fluoxetine, and both of them together can have a half-life that goes pretty much more than a day, pretty much can be 36 hours. So they have very delayed onset. However, this is the SSRI that is associated with the more delayed onset. However, it is associated with the lowest risk of withdrawal symptoms because of its very long half-life. Okay, fluoxetine is who's doing the consult? Yeah. So what's the SIP?
2d6.
2d6, yes. It has some 3A4. So 2d6 with fluoxetine is a big deal, and fluoxetine is the one who has the highest rate of drug-drug interactions within the SSRIs. Less commonly, paroxetine, it has a very short half-life. However, I had to put it here because it is also 2d6. Fluvoxamine is an interesting one. This is a 2E1, which is not that common. I think 2E1 or 2 and some, and there's one with I think 2A, and 2A, that's the one of nicotine, and you got the smoking and alcohol. Certainly citalopram, pretty much non-relevant, have very minimal drug-drug interaction. Certainly you can have some 2d6, but minimal. I'm not sure about the other ones. Let's see. All right, these two, citalopram and escitalopram, are the shortest acting. They have the shortest half-life, the lowest drug-drug interaction, and it's often commonly prescribed because of their fast onset. But the exception is citalopram possesses a warning, that is QT prolongation with doses above 40 milligrams. And you don't go over 20 milligrams if you are over 70 or you have risk factors. In the past, they used to dose citalopram to up to 80 milligrams, and after the warning came in, never exceed 40 milligrams. It's like simvastatin, for a different reason. So, and for patients at risk, you want to do more than 20 milligrams of citalopram. All right, now these drugs have very long acting. Being that very long acting, you needs to taper before discontinue. All of these drugs needs to be tapered before discontinue. Maybe not the talking that much. So pretty much a 10% reduction every week for up to, and the tapering duration can take up to 6 months almost. Pregnancy, they are all relatively safe in pregnancy with the exception of paroxetine and sertraline. They're terrible for pregnancy. They have been associated with pediatric portal hypertension and some abnormalities. So sertraline and placenta rupture, maybe I forgot. So sertraline, paroxetine are not to be used in pregnancy. They are all safe in peds, but fluoxetine is the one that has an FDA approval for peds. Okay, suicidal ideation. With any antidepressant, you're gonna see suicidal ideation. Not very much understood. Why do you get it? The idea is that when mentally you feel more relaxed and active and you start gaining functionality, you may engage in high-risk activities, and with many stressors, environmental, that may opt the patient to commit suicide. So the warning for increased suicidality has been shown only in patients less than 26 years of old, and pretty much that's especially between 18 teenagers, adolescents, less than 26 years old. Above 26, the risk of suicidality was rare. In case of intolerance or lack of function, you can switch within classes. So not just if you did not respond to fluoxetine, doesn't mean that you need to switch. In case of tolerance, same thing, but again, intolerance may be taken for different thing. All right, SNRIs. Questions about SSRIs? Yes.
I remember a pharmacist used to tell me, make sure you counsel on patients that they will kind of experience a little bit more anxiety when you first start SSRIs, and it'll kind of level off. Is that because of the AT2A?
I don't know, probably, maybe. But the idea is that they are known to be an activating. That's what the idea about the activating. And that's the idea is that because of this paradoxical increased anxiety you have, and you dose them in the morning, and you would avoid them in pretty much risk, like a manic state in patients.
And I think they also mentioned that the libido is the one that is the one side effect that usually doesn't go away.
Yeah.
Right?
Yeah. So, no, sexual dysfunction is a big deal for these drugs. Oh, I forgot to add, SSRIs has no other use besides depression and anxiety, because TCAs, we know they can be used for neuropathy. All right, SNRIs. SNRIs is serotonin norepinephrine reuptake inhibitor, just like TCAs. But the difference is they are still more focused on serotonin. And literally, this addition of norepinephrine to the reuptake inhibition is not going to constitute anything regarding to safety, efficacy, and you can consider an SNRI antidepressant just like any other SSRIs. Of course, it's not, but just an idea to give you an idea about their side effects. So literally, they are activating, they are dosed in the morning. We have 3 agents here. We have venlafaxine, desvenlafaxine. Yes, sir, duloxetine. Who did the consult on duloxetine? Did I consult on duloxetine? No? All right.
That's the brain. That's not the skin.
That's venlafaxine, so it's a venlafaxine that.
I know, I still remember the brand name for that.
Pristic.
Yeah,
Venlafaxine, Pristic, and Cymbalta, or Effexor. Okay, this one has a very short half-life, so it's given as extended release, you know this. They are almost always one of those once daily. So the idea is that especially venlafaxine, that's the only side effects special about it here. It has a dose-dependent pharmacology. So you are serotonin more than norepinephrine. However, when you dose it, I think more than 120 milligram a day, when you go above these dose, you'll pretty much start inhibiting norepinephrine uptake, and you may have a dose-dependent increase in blood pressure and cardiovascular issues. As you increase norepinephrine more, you get more tachycardia and hypertension. So only venlafaxine has been shown to have this dose-dependent. Maybe duloxetine, I'm not sure. I've never seen duloxetine in such high doses. But when venlafaxine, you go over 180, not 120, 180 to 240 milligrams a day, that's when you're gonna start seeing these side effects. Other than that, they are pretty much identical in terms of their venlafaxine, and this venlafaxine has minimal drug interaction. Duloxetine has some 2D6.
Does venlafaxine just last longer than venlafaxine?
I don't know. This venlafaxine has not been commonly used, and I'm going to tell you why. This venlafaxine is the only one that has been shown to have liver toxicity, and the use of Pristic has really fallen out of favor ever since. And so this one is the only one that has some event of liver toxicity. Duloxetine, some 2D6, and duloxetine is not that commonly used for depression. It is most commonly used for neuropathic fibromyalgia. So any condition where you have neuropathies with coexisting mood disorder or a functional disorder like fibromyalgia.
I've seen it used for sleep a lot.
Duloxetine?
Yeah, is that something that you?
I'm
not sure that maybe
wouldn't be the best option for sleep. There are much other agents to be used. Even within the antidepressant, you can use something like trazodone maybe or mirtazapine, but duloxetine for sleep. No.
I would imagine they use that as like an underlying something along.
Yeah, probably some.
Like
Again, it's
secondary.
very messy in the psych world, and you get to see all these drugs being prescribed. And something you may go, it's like there's a restless leg syndrome somewhere. There is some kind of literally, it's pretty much vague. And I've dealt with antidepressant and psych use, and like nobody followed these. And primary care provider starts someone on fluoxetine, and the gynecologist puts someone on sertraline, and they just like don't know, no Medrak, and you got this mess everywhere. Yeah. So I'm sure you've seen so many double antidepressants, so many things, even within the same class, which doesn't make any shred of sense to use of the same class. You may combine this, and this is called augmentation therapy. So the issue is from augmentation therapy is to combine two antidepressants in conditions where you have failure to a one or more than one agent. So you combine ibuprofen, you combine an aripiprazole, you combine a venlafaxine, but only in very low doses. And you would want to combine something of a way different pharmacology, something like ibuprofen or mirtazapine to the SSRI or the SNRI. All right, well, and DRI, ibuprofen, norepinephrine dopamine reuptake inhibitors. So here we are completely out of these, and we have only one agent, which is the amazing bupropion. Cheap cocaine, they call it. They shoot it. They put it, they crush it. It looks white, and they shoot it. And because of norepinephrine activity, it can cause vasoconstriction, and it can cause extravasation and necrosis. So yeah, it's a big deal when they shoot bupropion. It's very cheap, that's why they use it. And when I told you cheap cocaine, you understand there will be some kind of activation or inhibition. Activation, and bupropion is a very activating antidepressant, meaning it literally causes insomnia, it literally can precipitate psychosis, and should not be used in patients with seizure. And never use it for patients with eating disorders too, because eating disorders have high risk of seizure, and that drug could worsen it.
There's a black box warning for it, isn't there?
Yeah.
Like as a suicide ideation?
Yes. Suicidal seizures, all the kind of bad things in eating disorder. So, bupropion has a very short half-life, therefore there's going to be immediate release, and that's going to be TID, and there's going to be sustained release, that's going to be literally BID or TID. There is also extended release, and that will be PID. Even so, keep in mind that even if you have this extended release, you're going to still use it twice daily. All right? Now, it has a lot of forms, and I forgot about conversion. Basically, the range for it is 150 milligram per immediate release single dose, and maximum daily per tablet is 450 milligrams. So you wouldn't want to go above 450 milligrams of bupropion, especially for the sustained release, as bupropion has been shown to have, especially the extended release formulation, or the sustained, I'm not remembering, has been associated with liver damage. And based on that, recommendation came in so that the immediate release dose doesn't go above 150, and the extended sustained release dose doesn't go above 450 a day. So no 150 per dose, no more than 450 a day. Yes?
Can you remind me the difference of sustained release and extended release?
Yeah, it's just a way of that. So usually you want just the dosage form or just in terms of administration. Sustained release.
Dosage form.
The sustained release is only one layer. So you got pretty much the drug, a layer of the drug, and a layer of a coat, and this gonna give you this gradual release. Extended release, multiple layer and coating. So you get a layer of the drug, a coat, another layer of the drug, and a coat, and another layer of the drug, and a coat. So the coat dissolves, the drug release, then a coat will again and gives you more extended. Usually extended release drugs are over 12 hours, administered sustained release over 8 hours. Okay, so bupropion, very short acting, fast onset, activating, it causes weight loss, it causes insomnia, it causes psychosis, so eating disorders are out. The drug, literally it's activating, has zero sexual dysfunction, and that's why actually addition of low doses of bupropion to SSRI or SNRI can decrease the sexual dysfunction, okay? Bupropion is often added as part of what we call augmentation therapy in treatment-resistant depression to an SSRI or SNRIs just as much as aripiprazole is also now approved and added as augmentation therapy, yes.
Is it helping with sexual dysfunction because you now require less SSRI, or is it helping because it actually
no, it's by observation the addition of bupropion may be as the whole risk of sexual dysfunction with these drugs are not completely known, so that's why bupropion, but when you add it, it just takes it away, maybe from the mood perspective, I don't know.
Okay.
Yes.
I think one of the doctors at the toxicology told me that this is the medication that most doctors prescribe to like adolescents because it doesn't make them sleepy and it's very activating.
Yep.
And like as a result, it's like the one that we see the most overdosed on in the hospital. It's the most serious one because it causes really bad seizures once you get to really high doses.
Yeah. Precisely. Again, you need it for an adolescent. It doesn't cause weight gain. It doesn't have sexual dysfunction. It doesn't impair sleep. So it makes sense to be very commonly prescribed. Again, it is multiple times per day. So this is also makes sense for adolescent. Yes.
When you're adding it to an SSRI for the sexual dysfunction, you said it's a low dose.
Yeah.
Is it like 150?
Something like
three times a day still, or just once?
Something like a once daily dose in the morning, maybe.
Okay.
Yeah.
Just once.
And again, once daily, twice daily dose of the immediate release and monitor, evaluate response. So really, there is no direct guidance. And now it's moving more towards aripiprazole because the study came in last year and the study was on. I don't think there's an RCT on bupropion addition for me, may check. But aripiprazole has been completely well known and done in the good studies. What else about bupropion? Yeah, that's it. That's enough.
Could you remind us about the dosing with regards to treat depression and for smoking cessation?
Good. Thank you for reminding me. Bupropion has another indication and a different dosage form. So the dosage form, the brand name for depression is Wellbutrin, and that's the XR or the IR or the SR, and there's Zyban, which is for smoking cessation. The dose for smoking cessation is fairly easy, and it's a weekly tapering of 150 followed by, double the dose of 150. I think you can reach also 450 a day. So the idea is that you would want to start it a week before smoking cessation because it takes time. But yes, it has an indication for smoking cessation, and the dose is the same. You start with 150 and you go on until, 450.
Does it have an indication for weight loss too with naltrexone?
Oh yeah, isn't it? With naltrexone? Again,
Combine.
when they combine the topiramate, we also, the epileptics, there is a combination of phentermine. And I'm really not seeing this product as being, is it widely used?
Well, I know like in the compounding pharmacy, they'll come to us for like low-dose naltrexone, and then they'll get bupropion through their regular provider and just take them together.
Oh,
Because
really?
there's like a combined product.
Oh, I
that's
never knew
expensive.
that.
I've never heard, I mean, there is no product that is approved of this combination, isn't it?
Yeah, I have to look up the name though, but it's like,
Does that suppress your appetite? Is that what it is?
Yeah, that's how the bupropion will work. It's not increased norepinephrine, just like how cocaine or any of these appetite suppressants work by, like Sudafed, any of these phentermine, any of these appetite suppressant increase sympathomimetic activity, and that will increase to increased appetite.
find it, John?
I didn't find a name for the just a study.
Crazy.
I'll look for it.
Maybe there's like a Tylenol, like omeprazole.
Okay, I'll leave MAO inhibitors as it's not that big deal. Let's talk about SARI, and we're gonna continue with our psych review for the next one. So last thing is serotonin antagonist reuptake inhibitor. So here we're gonna start antagonizing some peripheral serotonin receptor, well, systemic, but which one of these you wanna block? Two. Yeah. So serotonin, SARIs, trazodone, and nifazodone, these agents inhibit the postsynaptic 5-HT2A, and at the same time they inhibit the reuptake of serotonin. Now the product is trazodone, and nifazodone was a drug designed to overcome the side effects of trazodone. So I'm going to talk about trazodone. Short-acting agent. And you know very well from trazodone it possesses two very important, three side effects. Extreme sedation, orthostasis from alpha, extreme sedation from histamine, and lots of sexual dysfunction, especially priapism. So sexual dysfunction from trazodone is a no joke here, as much as big as it is in the SSRIs. Add to that the sedation, and that's why you see it used at doses of about 100 milligrams, 50 milligrams, and these are the low dose, usually the starting dose of trazodone, in order to use it as an adjunct for sedation with coexisting depression. So trazodone is often added for this purpose. Rarely it is used as the main agent for depression because higher doses can cause more sedation. So, and orthostasis, and that could be dreadful for some of the elderly. In addition to it, the sexual dysfunction. Nifazodone was a drug that kind of modified structurally to not to have the sedation nor the orthostasis hypotension. However, nifazodone was found to be liver toxic and boom, out of favor. Just like this, venlafaxine is out of favor. Yeah, pretty much I think we're out of time. Next time I'll do mirtazapine, some mirtazapine, MAO inhibitors, and carry on to other classes like these new vortioxetine and vilazodone, some of these new antidepressants. All right.
What did you say the place in therapy was for trazodone?
As an adjunct for insomnia or coexisting depression.
Okay.
All right.
Hey,
Thank you.
how do you know all these names? Like you can just pull